One of the biggest issues from medication shortages is ultimately the impact that it has on the patient.
So some pharmacies will just state this medication is unavailable.
People who, like we were saying before, don't like change.
The branded Aston is at 10 milligrams, or you've got alternatives like you can use amlodipine 2.5 milligrams.
I only knew that because I knew the pharmacist that worked there. I said, can I have my old brand, please? He said, oh, we've actually switched over permanently now because it's saving the pharmacy money effectively. Welcome to the Ashtons Primary Care Podcast. My name's Nicola and I work within Ashtons Virtual Hub for Primary Care, helping primary care networks drive digital transformation and enhance practice efficiency. Today we're tackling an issue that's affecting pharmacists, GPs and patients across the UK, medication shortages. From supply chain disruptions to regulatory changes, shortages have become a persistent problem, creating pressures on primary care teams and increasing the workload for pharmacists. So how do we navigate these challenges effectively, and what role can innovative models like the Virtual Hub play in supporting primary care networks? Joining me today are 4 pharmacists from our Ashtons Virtual Hub team. They'll share their experiences, insights and practical solutions for managing medication shortages whilst maintaining patient care as a top priority. We have Irfan, our lead pharmacist from the primary care team, Shakir, our PCN lead and clinical pharmacist, Raymond, one of our clinical pharmacists, and Ravinda, one of our clinical pharmacists also within the primary care team. Welcome, everybody.
Thank you.
Thank you.
Hello.
I guess a good place to start is with your guys' perspectives on how medicine shortages are affecting pharmacists, GPs, and patients within primary care. Fan, do you wanna start?
Yeah, so I think a big part of it is, especially when we're dealing with medication queries or prescription requests, an increasing volume of those are medication items that are unavailable, that are out of stock, that have not been available for a long time. So we're having to change dosages, look at alternatives, suggest other things to the GP. So I think it does definitely take up a lot more time, and we're obviously doing as much as we can to minimize that work for the GPs, because what they don't want to do is have a massive list of tasks on their desk that this is not available and they're having to do research. So where possible, we're issuing medication as an alternative, or if it needs more clinical input, we're suggesting suitable alternatives, having done the research.
Would you say it's easier for a pharmacist to offer those alternative medicines over a GP because you have that community pharmacy experience?
Yeah, absolutely.
Yeah, I think that's the main thing, isn't it? I think that we're kind of like really well positioned to immediately think to ourselves, okay, in community pharmacy, if something is out of stock, this is what we have as an alternative. So we know those alternatives straight off. It's not like maybe a doctor or a nurse needs to kind of go and research that. Well, what else is available? I think we're all familiar with what's available, and so sometimes it's just so straightforward. So, for example, a particular brand of inhaler is out of stock. That's fine. That particular medicine is made in via different brands, different manufacturers. Just switch it over. It just takes a minute, but it avoids the doctor or the nurse or someone else having to kind of do that research and phone up. It's just a quick switch, and then the patient can get their prescription straight away.
Yeah, and I think who else would be better to provide alternative medication than a pharmacist whose expertise is medicines? So I think we are in a better position to provide alternatives, suggest alternatives, and put that forward to the GP.
What's your opinion on when, like you say, Shakir, rather than it being an alternative medicine, it's sometimes just an alternative brand of medication? Because I know from my experience, I was on the same asthma inhaler for my whole life pretty much, and then my brand suddenly got switched and I thought, oh, they've issued me the wrong medication. That was my first immediate thought, because it looked completely different, obviously knowing now that it's exactly the same medication, exactly the same dose. But as a patient, you sometimes feel, oh, well, I don't want to change because I've been on that medication for so many years. Is this going to affect the efficiency of the medication? Is that something that you see with patients? They're reluctant to even change brands of a medication?
Always, yeah. Patients, anyone doesn't like change, and so therefore, especially when it comes to medication, people are very, very possessive of their brands, and don't like for it to be switched over. I think the most important thing is that normally when the request comes to us, the problem has already been identified by the pharmacist or by the patient that something is out of stock, and can I please have an alternative? So in this case, I think they appreciate the fact that an alternative is going to have to be prescribed because something is out of stock. And so we normally leave a little note on the prescriptions to say that the reason we're giving this is because something is out of stock. So there's a note there, and then obviously we are expecting the community pharmacist, when they issue the actual prescription, to actually obviously say that, look, and counsel the patient however they need to about the brand switch.
Thank you.
That's it. It's about communication, isn't it?
Yes.
I think
Nicola, just to jump in there as well, I think the virtual hub is well placed in that sense that, as pharmacists, we're able to speak to patients on that matter and give them the reassurance about the switch, and just let them feel more confident in trying the alternative medication that is issued.
I
And
think just
also, if
to
they
add,
have problems, sorry, Ifan, if
Go
they
on.
have any problems, they can always get back in touch with us through the surgery. There are other brands that we can issue as well. So there's always a solution.
I think just to add to that as well. So following up on what Raymond said is the communication aspect. So yes, where possible, we can speak to the patients. However, if you've got a list of 100, we might not necessarily speak to every single patient. So things like AccuRx, which we use alongside the practices, clinical systems, they're quite a good tool for simple communication, just to allay the fears of the patient, just to give them the expectation that the medication this month is going to be slightly different. And I know, Nicola, you mentioned about different brands. Sometimes there are a lot of cost-saving initiatives within the NHS. So each area has its own formulary. So sometimes, for example, Ventolin is no longer on the formulary, and they might be prescribing a Salmol now. So where possible, patients are informed of that, just to make sure they're aware of the changes.
And also just informing patients, there's when you're sending the alternative prescription request, you can also add script notes for the chemist to read out to the patients too, or they can add those onto the direction on the labels of the prescriptions as well. So the patient can be told multiple times as well if you can't physically get through to them on the phone.
Yeah, there's many different platforms and several ways you can communicate that to the patient to give them as much reassurance as possible. And it is all about just making sure you've relayed to the patient, it's the same medication, it's just a different brand, it's still going to be effective. That's what you're saying, Afan, in terms of community pharmacies saving money. That was exactly what happened with my brand. They actually switched the brand because they couldn't get hold of the previous brand of inhaler. And once they'd made that switch, they actually realised the new brand was cheaper. So they made that switch going forward. I only knew that because I knew the pharmacist that worked there. I said, can I have my old brand, please? He said, oh, we've actually switched over permanently now because it's saving the pharmacy money effectively. But that's something that sometimes GP practice might not consider, of not having that community pharmacy experience. Is there any sort of industry pharmacy secrets that you guys have working within community pharmacy that GPs might not be aware of?
Interesting question. I think in pharmacy we tend to start out in community pharmacy, or hospital, and for us, I think all of us have started out in community, so we do have this hands-on experience, where when medicines are unavailable, the alternative switch. So for example, there's a lot of trends in certain communities in terms of prescribing trends that we can follow, and this helps to guide us as well with making decisions.
I think one of the real advantages of the virtual hub is that you're kind of like I'm not going to say isolated, but because you're slightly removed, you're not in an environment where lots of things are happening. Like in a community pharmacy, there's lots of things happening. In a surgery, there's lots of things happening. So when you're working in a virtual hub, you've got the time to kind of step away. You're not distracted by the things. Sometimes the switch is easy. sometimes it can be a bit more complex. And so sometimes you need to do a lot of research. What is available? What is out there? You know, what is the equivalence of one medicine to another medicine? And if you're busy and you're getting lots of distractions, it's really hard to make that decision. Now, the advantage that we have in the virtual hub is that we have all the information available to us. We've got all, various windows open. We've got the BNF open. We've got the SPSE open, the SPSS open. We've got various windows open, and we also then have the other advantage of if you're isolated in a surgery or in a pharmacy, who do you contact? Whereas we've obviously got a big network, and we can then contact each other. So if I have got a query and I think to myself, well, I think it's the right thing to do, but then I can contact Irfan, contact contact Raymond, and say, this is what I'm thinking. We've got a problem, but we need a solution. This is what I'm thinking, and then you get that kind of backup, and to confirm what you're doing is right. And that's quite a specific advantage that we have working in a virtual hub that you may not get working in other environments.
Yeah, that's super interesting.
I think also working with, because we work across the country, so different areas, plus on top of that, we have our own dispensary. So we have quite a bit of insights in terms of the availability of items. So where possible, we might, if something's unavailable, we might actually advise the patient try another pharmacy if we know that the item's available, to stop them having to try something else, which they might potentially have side effects from, or ideally the patient's taking the same medication. Also, just to add that an example was when the ADHD medication was, there was a lot of problems sourcing ADHD medication. So a lot of pharmacies basically were giving out messages to say what they have available. However, because we've got some expertise in mental health and ADHD in the wider team, and there's good guidance from SPS, we could see about the release profiles to see what actually is what alternatives are suitable and suggest those to the GP rather than just leaving it up to the GP to decide.
Yeah.
So just giving them as much information as possible.
Because as a company, we all receive that supply shortage email once a week, don't we, with what's currently out of stock, and then an update on when it's coming back into stock, the long-term effects of that supply chain. How valuable is that for you guys in what you do day to day for patients?
I guess it gives us a heads up, isn't it? Like day to day, every single day there's a medicine going out of stock. So every single day you're getting alerts. And it gives us a chance to stay ahead and already put our brains together and be like, okay, like for example, the methylphenidate was out of stock. We could already start talking amongst each other what could be the alternatives. So we're keeping one step ahead when we receive those emails, which is really good for our team, and also really good to have a suggestion already waiting there to, for the doctor's surgery when we get those tasks sent over to us about medicine stock issues.
Yeah,
I think, just adding to that, so when it's like a key medication item or quite a complex medication shortage, then sometimes we can just get together as a team and just identify the best solutions, and then sometimes that does include meeting with the practice as well. So I think a good example was when there was problems with some of the GLP-1s, the Trulicitys. So I met with one of the GPs at the practice who's a diabetes lead, because it was becoming increasingly difficult. So patients were struggling to get the medication. They were trying to get different doses to double up and things like that, which isn't ideal. But again, even those were going out of stocks, then the recommendation from the GP initially was tell the patients to go to pharmacies further afield, but that's quite problematic for the patients. And again, sourcing the medication was increasingly challenging. So we agreed a plan that we could switch them on to semaglutide. However, the problem with that was it had been, the GP's viewpoint was it's not necessarily as effective. So where possible, we'd try and keep them on the injection if they could get it, but at least we had a alternative solution to offer.
Yeah.
I guess one of the biggest issues from medication shortages is ultimately the impact that it has on the patient. I mean, the patient impacts could range from a patient spending hours and hours ringing around several pharmacies just trying to locate anyone who has stock of that medication, all the way to not having what they need when they need it, and ultimately ending up being seriously unwell, ending up in secondary care, which adds an extra pressure onto secondary care that could have been avoided. I've even seen or heard of patients trying to source medications from unregulated suppliers, which obviously comes with its own risks and implications. What has your guys' experiences been with patients that are desperate and frustrated and ultimately at their wits' end with the
I don't think
situation?
that's not normally a problem, is it? If I'm honest with you, people are very, very particular about the medicines. They don't like to go to, like, non-reliable sources to get their medication. I think the only thing I've come across before is, I don't know if you guys agree, but maybe when they take their partner's medicines.
Yes.
So for example, someone's got like cocodamol maybe, and they're like, oh yeah, my husband's got tramadol. It's kind of similar, isn't it? So they'll kind of like take some of those. I think that sometimes happens. Yeah, switching between partners. But otherwise, that they don't want to risk normally going to unreliable sources to obtain their medicines.
Yeah. But the key thing.
Sorry,
go ahead.
Romy,
Ladies first. Go ahead, Ravinda.
I was going to say, the quicker they let us know that they can't get hold of the medication, the quicker we can find them a solution, whether that means speaking to the GP, seeing if there is an alternative that we can suggest within primary care, or if not, like, we can also refer them back to secondary care. So, for example, if it's somebody dealing with like epilepsy, and we can't get hold of like an alternative in primary care, we can send them back to neurology, and there will always normally be an alternative medication that the consultant will suggest. So there are ways around things. It's just communication and keeping patient safety at the front of everything that we do.
Yeah.
I think you're trying to avoid the time wasting, aren't you? Where you're just toing and froing from the pharmacy to the doctor, and what about this, what about that? And you just need someone to kind of maybe step in and say, well, look, there's an issue here. But there isn't an obvious solution. And sometimes, like Raf's saying, you have to kind of say, look, we're not going to be able to find a solution ourselves. It needs to be kind of like escalated to secondary care. But it's just a case of expediting that to keep it as safe as to keep the patient as safe as possible. What you don't want is for it to kind of linger on for like weeks and weeks and weeks in the hope that something might materialize. And as we know, some shortages, they last weeks, months, a number of months. So therefore, it's just a case of just trying to do it as quickly as possible. And I think we're positioned in an ideal situation, in an ideal position to expedite that as quick as possible. Yeah.
I think, Nicola, going back to your initial point, I think treatment failure is probably the biggest concern from medicines being unavailable, because, for example, if it's diabetic medication and it's, they've managed to get their blood sugar levels down, suddenly being without their medication, their risk of that increasing again if we don't give a suitable alternative, or they have side effects from the alternative. Same with the methylphenidate example. Again, the patient's quite well controlled on the ADHD medication, and suddenly they're having to go without it, or they're missing a few weeks. So I think treatment failure and then setting them back is one of the concerns.
They say sometimes very not very often, but sometimes it can be a positive. They kind of say necessity is the mother of invention, in the sense of something's out of stock, the person is prescribed something else, like a different antihypertensive, and they find that the different antihypertensive actually works better, and they've been on the same medication for a long time, and it was okay, but they switch over, and it's either better, or a side effect kind of like, is resolved, and they say, oh, I didn't realize I was getting that side effect from that medicine. So, it doesn't happen very often. But
and sometimes be a positive.
Sometimes it can be, yes, that's right. So sometimes switching, because then people who, like we were saying before, don't like change. And so therefore they want to stick to what they've got. Even if, we as healthcare professionals are suggesting, look, this is better for you. And sometimes when push comes to shove and they have to change because something's out of stock, it's sometimes, sometimes an opportunity maybe to try and switch them over to something which is actually a bit more effective.
If I could just add in that, the key thing here is that through the virtual hub, we're able to speak to these patients and offer them the reassurance that they need and help them to find the solution. A lot of times patients are booked into reviews with us because they're having issues with sourcing their medicines, and these patients were able to speak to them and signpost them, even us calling the pharmacies, the community pharmacy themselves, and finding out what they have in stock and what they're not having issues sourcing. And without the virtual hub, some surgeries wouldn't be able to make these changes in a timely manner. So I think we have been really resourceful for these type of surgeries in helping them and their patients in this manner.
I think even from the community pharmacy viewpoint, I think we get differing examples. So some pharmacies will just state this medication is unavailable, so then we have to do the research and maybe do the legwork, maybe contact them to say, actually, do you have this available? Whereas others are actually quite more bit proactive and say, this is not available, however, we have this strength, you can just double up, or this is a suitable alternative, please check if this is suitable. So that does help, in fairness.
I think that's general kind of a rule, isn't it, where if someone suggests something, it just makes it so much more easier.
It does.
So for example, when we make a suggestion to the doctor, it's not a case of like, oh, here's a problem, but look, here's a problem and here are one or two possible solutions. And in the same way, when the community pharmacy maybe sends a message saying something's out of stock, I mean, it's brilliant when they turn around and say, but this is
available.
Mm-hmm. Yeah, precisely, exactly. So yeah, I mean, I think when we speak to community pharmacies, maybe kind of on the phone, maybe sometimes, maybe kind of, especially the regular pharmacies. So for example, like one of our pharmacies in Billericay, like Shadforth's, when we speak to them, we should actually be saying to them that look, if something is out of stock and you send a note to the surgery, suggest an alternative if you can. So let us know what's in stock so that we can then prescribe that particular medicine. I think that's a really, really good suggestion.
Yeah. And I think that's something we want to do more and more of actually liaising with these local pharmacies.
That's it.
Building that network, just so everything flows a lot better.
I'm guessing it must be really frustrating for a patient if all of those things that you've suggested, you guys within the GP practice suggesting an alternative, if not the community pharmacy actually suggesting an alternative themselves as well. But if it gets past those two stages and it gets to the patient where they've been prescribed something that they can't get hold of, the patient is then possibly ringing around multiple pharmacies to try and find that medication. Who would you say whose responsibility is it to make sure that patient receives that medication that they need?
I think Rab is best placed to answer that.
Good question.
I would say that we've all got a responsibility, equal responsibility. The patient has a responsibility of informing the surgery that they can't get hold of the medication. Once that task comes over to us, it's our responsibility to suggest alternatives, find solutions, forward that over to the GP, get that clinically approved, for us to act as quick as we can to find the solution and get a prescription sent back to the chemist so the patient can have the medication and obviously continue their treatment. So I would say equally, everyone who interacts with that patient's task is responsible for making sure that task is fulfilled. I think. What do you guys think?
I agree. I concur.
Very diplomatic, Rav. Yeah, no, absolutely. No, but you're right. Though. You're right. I think we obviously want the patient. Ultimately, the patient is the person is the person that has to have the medication. So you do want to try and empower the patient, and I do try and say to the patients that look, sometimes you have to push it yourself. Yeah, sometimes have to kind of like if you've tried your best to find it, you must come back to us. Don't just leave it. You must come back to us because we can only do something about it if you inform us. So I whenever I speak to patients, I always do say to them, that take responsibility for it, but do let us know, because the doctor or the pharmacist can't do anything unless they know there's a problem. So that it's important for the patient to take that responsibility as well.
Comes down to communication again, doesn't it, between all parties?
As long
as everyone's communicating, then it should flow well. But when that communication breaks down, that's when the patient is going to end up with issues. So what would you say to a patient that feels they're being a burden to the practice, keep ringing, keep chasing. What would your advice be to a patient that's in one of those situations?
You do speak to patients and they feel as though they don't get good responses if they don't get good response from the surgery, they don't feel as though they can go back to the surgery. They don't want to disturb the receptionist. They don't want to disturb the doctor because they've had a bad experience in the past where they felt as though, oh, I'm just annoying the surgery. And then if they've got a problem, like a real problem, they feel as though, oh, maybe I shouldn't speak to the surgery, but obviously they should. Obviously, I see so many people, they kind of turn around and say, oh, I didn't want to disturb the doctor because of this whatever reason, yeah. And I'm saying, look, no one's health is more important than your health. You can't turn around and say, oh yeah, there are more people that are needy than me. If there's a concern there, you feel as though there's a concern, you have to raise it. So it's just a case of trying to empower the patient as well.
And just
as much as you
touching
can.
upon that as well, like, how you said sometimes the patients don't want to contact the surgery because they've had bad experiences. Sometimes patients say they can't get through to the surgery. So if they have a platform where they can just send a note to say, I've tried to order my medication, and like, for example, atorvastatin, I've tried to order it, it's out of stock, I can't get hold of it. This is where like the virtual hub is also an advantage, because the message will come straight through a prescription task, and then we pick it up straight away. So you're already delaying the time for the patient to pick up the phone, to ring the surgery, wait an hour to get through. We're already dealing with it quicker.
Yeah, that's a prescription request, like either a prescription request or sometimes even an e-consult.
Yeah, the e-consult sometimes as well.
Yeah, but then absolutely right. Yeah, obviously we're living in a technical age. Sending a message just immediately kind of pops up. Whereas, like I'm saying, when you're picking up the phone and then you're on the phone for hours trying to get through to the surgery, that's obviously more trickier. Or you have to go in physically yourself. That will take time. But to send a message is very quick, and then it can just immediately be zipped over to us, and we can try and action it straight away.
Yeah.
And then send a message that, look, it's been actioned, a new prescription's been sent out to you. It should be ready to collect in the next, this afternoon or tomorrow morning. Yeah, that's a good point.
And also, oh, sorry, I was just going to say, this is a bit of a separate topic to what we're talking about now, but working for Ashtons, I'm already working on a project for them at the moment where they've got a list of all the medications that we use, and I'm already working on clinical alternatives. So we've got a spreadsheet already in place where we have got alternative medications already suggested. So we're already a step ahead.
Yeah.
So that's just something that I've been working on separately for Ashtons. So in terms of the virtual hub and what we offer as a company, we're already a step ahead in terms of medicines management and supply issues.
I think always what you're doing then, Rav, in that case, you're kind of creating a database, are you, where if something is out of stock, there's an alternative there.
Yeah.
And
so
once that's in the database, then it can be used the next time it's out.
So for example, like I'll just keep it simple, like amlodipine, say like 10 milligrams of amlodipine has gone out of stock. I've created a spreadsheet where we have already got alternatives in place. So like the branded Ashtons is at 10 milligrams, or you've got alternatives like you can use amlodipine 2.5 milligrams, 4 tablets a day to make that 10 milligrams. You've got amlodipine 5 milligrams. So there's alternatives already in place for those issues that might arise with stock. So I think that's one of the advantages of working for Ashtons, and also this virtual hub that we have created between us. We're already one step ahead.
Just changing the subject slightly, so looking at the cause of why certain medications do go out of stock. I mean, there's several causes for this, right? I mean, raw material shortages, increased cost of manufacturing. But I think one of the biggest ones was Brexit slowing down the entry of medications into the UK. Did you guys notice a significant difference once Brexit had happened and the repercussions of that?
At the time it happened, I was working in community pharmacy, and about 2017, and we did start noting that medicine supply shortage started during that time. We had to be ordering and stockpiling medicines during that time, just to make sure we had enough medicines to supply to our patients.
I think different manufacturers were struggling to get hold of different brands at that time. So I think there was a lot of alternatives that we had to suggest, working in community as well at that time as well.
I think there's always been, the odd medication that's been unavailable, but I think the sheer volume of medicines that have become unavailable since has definitely increased, and even more simple items. I remember when alendronic acid, for example, became unavailable, either because of a shortage or because the cost of obtaining it for pharmacies was so high that it didn't make sense for them to actually issue it because they were actually losing money. I don't know if it was for that or atorvastatin, but yeah, one of those. I think it just became financially ineffective for the community pharmacy to actually dispense that medication.
Ravinder, you mentioned that there are the tools there for the patients to get in touch. If they have a problem with their medication, they have the tools to get in touch with the GP practice, and like something like the virtual hub is able to act on that pretty quickly. I'm guessing that depends on how digitally advanced the GP practice is. Some practices might not be able to offer that service yet. What's your opinion on how a GP practice should operate in terms of being digitally advanced?
I haven't come across a surgery that hasn't got a repeat prescription service already in place. I'm not sure about you guys, if you guys have, but most of the surgeries across the UK that I've worked for have always got a repeat prescription service in place. So whether that's online or you bring the prescription slip into the surgery, there's always a service available.
I think it's what you said before, Rav, isn't it? That if you raise the query digitally on a digital platform, then you don't have to walk to the surgery. You don't have to get a bus to the surgery. You don't have to wait for your son to take you to the surgery to put your repeat slip in, or to put your note in to say with a letter saying, I know this is, Mrs. So-and-so, and this medicine is out of stock, and I need it for this reason. You just can go online. You can just send a message quickly, to the surgery. We can pick up those messages, and sometimes within half an hour, if it's red flagged, as urgent, sometimes within half an hour, 45 minutes, a pharmacist is addressing that, and sorting the problem out. Hopefully, within minutes, and that's all available via the digital system. So yeah, it's very important, and it can make a really, really big difference on how quickly we sort these problems out.
But have you guys ever come across where a surgery hasn't got this digital system in place? Because I don't think I have.
Yes, I think some surgeries some surgeries don't have as much uptake, or they're not as digitally enabled effectively. So in which case they are still very much, patients are going in, dropping off the repeat slips. Then I think, to be honest, it's less efficient for the practice and for the patient. With the online ordering, it does make it a lot more streamlined, and also it's more accurate. So obviously in the past there was the whole thing about community pharmacies ordering on behalf of the patient, and potentially people ordering medicines that's not due yet, but at least now the power is in the patient's hand, which is about patient empowerment.
Yeah, when you look at it, if it's a repeat prescription service though, what would you say? What's the turnaround time normally for a prescription service? It's 48 hours, isn't it?
48 hours, yeah, exactly.
All right, so you got a problem, and you put the repeat prescription. You put the query into the repeat prescription service. Someone might not look at it for about 2 days.
Yeah.
Whereas if you've sent it electronically, someone will look at it almost immediately if it's red flagged that someone's put urgent on it. So immediately the red flag. And that's why the red flag.
Yeah.
Especially with our team as well, like Amanda, who's part of our admin team, if it comes through electronically, it's already going to be flagged into our surgery folder already. So one of us are always working on one of the surgeries that we're allocated to daily. So somebody will pick that up if it's an urgent, and still the turnaround time is 48 hours. That if it's a red flag, it will get done within 5 minutes. So I think we're so efficient we can turn over that time a bit quicker.
I'm assuming some practices do have the facilities for the digital prescription queries, but if they don't have the workforce to action those queries quickly, then like you say, it's going to be that 48 turnaround rather than it being addressed quickly as we do within the virtual hub.
Looking at past surgeries, when we're saying 48-hour turnaround, I mean, if we've got a high patient volume and haven't got a team working on prescriptions, it can become a weeks process. Yeah.
And I think
we saw that with a surgery in the south.
Yeah.
Where the prescription queries were taking like a week or so to get done, until we joined them, we were able to cut that time down. So surgeries will have this challenge unless they have a team like us in place to support them with their prescriptions and the queries.
Because with some practices, it is sometimes, the doctors are doing the prescriptions in between their patients, in which case it's not like, allocated time and they can only get through so many.
And we should a shout out to our technicians. I think you mentioned our pharmacy technicians. So they're very good at being able to screen the prescriptions and identifying the ones that are urgent, the ones that where they need to be addressed more quickly, and then flagging them up to us as well. So there is a very good process in place within the virtual hub of screening the prescription, highlighting the urgent ones, and then us addressing those as well, because we see them as red flagged. So yeah, the system in place does really work very well.
Just to add as well, a few of our practices also add another layer of options for patients, so they allow patients to email in requests as well. So again, that's another digitally enabled way. Again, we then add them onto the system and red flag them if we see them as being urgent. Another thing to add also is it's quite important that medications are kept up to date on the surgery system as well, because if they're not, then the patient sometimes struggles to order, and that can prevent them using the online ordering, and they might revert back to paper because they can't see their medication, like a list of their medication anymore, and doesn't allow them to tick it, or just making sure that their repeats are up to date. So when a patient first starts the medication, it might be put on as acute, so the patient might struggle to order it, but once they're established on it, it should be added to repeats. It's important to get the medication review aspects completed as well in a timely fashion.
Talking about technology and practices being, digitally enabled, have you seen any new technology that's come in maybe the last couple of years that's helping with medication shortages or just efficiency of dealing with prescription queries?
I think the Ashtons database that Ravinda is working on is one such systems that we have in place that is supporting us and helping us. Irfan, you have a...
I was going to say, so with script switch, I haven't seen it that often, but when there's a wide shortage of medication, nationwide shortage of medicine, sometimes they do add pop-up alerts on there. So I think one that I saw recently was when Zapain was unavailable. So if you're trying to, issue Zapain, it will say, this is, there's a nationwide problem with sourcing it, please prescribe it as generic as cocodamol. The things like that do help. Also, as well as our own tools, there's websites like SPS who offer good dosing guidance. So especially for the more complex alternatives that we're investigating, having a good guide to look at the clinical, to understand the right clinical input really helps to get the right medication and the right alternative.
And of course, when the patients quite urgently wanted the prescriptions, sometimes they leave a message, don't they, to say, can you let me know? And obviously then we use that QRX, don't we? Because otherwise, how you send a prescription to the pharmacy, it's sitting there, the patient doesn't know whether it's received it, but we quite often send out messages, don't we, to say, an issue has been raised to us, we've dealt with it, and the prescription has been sent over to the pharmacy. Maybe please check this afternoon or tomorrow morning. So again, we're using the technology to keep the patient informed as well there.
But even just adding to that, then even the other bit of the communication. So whilst we're posting these prescriptions, if the patient is due a medication review, so then antidepressants that are due the review, we send them a text. In the past, we tasked the surgery to say, can you please contact the patient, book them in. But now we're empowering the patients. So as we're doing the prescription request, we're letting them know that okay, your review is due, or your blood pressure is due, or we're sending them even the blood test form to say, blood test due, please book in, or contact the practice if you're unable to print it off. So really just increases efficiencies of everything, and it makes life easy for the surgery as well, because we're dealing with a lot more percentage of the work that way.
I mean, you just covered a lot there, Fan, in terms of empowering the patient to give them as much information as possible. But what would your advice be to patients that are struggling to get their medications that they need? Because patients are told not to stockpile, but also not to let their medications run low. So it's kind of a tricky place for a patient at the moment.
Shakir, what do you think?
I think, well, the answer to that question is, on the whole, I think the patient's got to trust the system. I think that I don't think you can kind of like cater for potential problems, because who knows what's going to happen. But certainly ordering maybe a week in advance for the patient to be doing their normal routine. And I think it's down to really us that if there is an issue, for the patient to raise the issue or the pharmacy to raise the issue, and then for us to deal with the issue correctly and quickly. And that's what we're really good at. And then all the patient needs to do is just order at a timely manner, and just get into the routine of ordering maybe every 28 days or every 56 days, just so that they give the surgery enough time. But no, things we don't want. No one wants patients to be stockpiling medication at home, and then we also don't want people to be ordering at the last minute as well. So I think maybe ordering maybe a week, to 5 days in advance is fine. But when the problem does occur, then yes, for us to deal with it quickly. I think that really is the only solution there.
I think again, obviously, if they're going on holiday and they need the medication early because they're going to be away, then quite a lot of patients do put that note on. So again, that's another advantage of the digital tools that they use for ordering. So they just write the message saying, we're going away in a week's time. We'll be away for 2 months. Can we please get additional medication? So yeah, that's quite common things that we deal with. The other thing also is if they are ordering too early, it's something we flag to the patient directly and to ask them, this is a bit early, it's not due till next month. Is there any specific reason why? And if there is, then they'll come back to us. So yeah, usually patients are quite good in terms of ordering on time when it's due, about 7 days in advance.
What would your advice be to other pharmacists that maybe don't have the support that we have within the virtual hub? You mentioned that we have the network of pharmacists. You meet up and you can discuss medication shortages, alternatives. You have that community that you can lean on each other for help. What would your advice be to a pharmacist who maybe doesn't have that outside support, and he's just working within a practice and doesn't have that support team to lean on?
Wherever you're working, whether it be community pharmacy or whether it be in a PCN, it's your responsibility to contact the other surgeries, the other PCN pharmacists, and even if you're the only PCN pharmacist in your PCN, to contact the local ones. Just kind of create a network. There are various WhatsApp groups that people have. You can join them, and you can just send messages and say, look, I've got this slight issue. What can I do? Does anyone have any advice? What alternatives are available? So you just got to create your own kind of network for people who don't work. We're fortunate; we've got other pharmacists that we can lean on. But if you don't have that, try and create your own network as best you can on whatever format you want to, just so that you can quickly refer to them, and try and get some advice and guidance from.
And I think community pharmacy is like a wealth of knowledge as well. So for that same pharmacist, making links with their local community pharmacies, who a lot of their patient cohort would be using, would be quite ideal as well, because they can discuss these things like alternatives and work on suitable alternatives together, or small projects.
Definitely. And what is important as well is the community pharmacy will see different prescribing trends as well. So a pharmacist in that situation speaking to the community pharmacy can get very good advice in terms of what is trending based on what's happening.
And a similar question, really, what would your advice to GPs be, if they don't have that support as well, and they maybe have a very small team of pharmacists or pharmacy technicians working within the GP practice in terms of offering alternative medicines or keeping up to date with medication shortages?
Or I would say maybe they should consider engaging with a virtual hub like ourselves, so that we can offer them the support. And also maybe having a very good relationship with your local community pharmacies as well, so they can give you advice in terms of what is happening based on ordering patterns and availability of medicines. But they should really consider a virtual hub like Ashtons to support them.
And also I think GP surgeries or like particular GPs can also like sign up to MHRA. They always send out alerts as well for medication shortages or just like other information that we might need to know as well. So just keeping up to date clinically and with the right websites that look after medicines management.
A lot of practices that we work with have requested to receive our supply shortages email that we get internally and push that out to them so they can try and keep as up to date as we are with upcoming shortages or the status of something that's out of stock. So that's really helpful as well to pass on our knowledge to our practices so we can be as transparent and communicate as best we can.
Absolutely.
So guys, I think we've covered a lot today, from the root causes of medication shortages, the impact on pharmacists, GPs and their patients, and how innovative models like the virtual hub can ease some of these pressures. And it's clear while shortages are a growing challenge, collaboration, ability and technology can play a key role in finding solutions. Well, thank you so much for your time today, guys. I know you're very busy with clinics and practices, so I really appreciate it. I think we've had some really interesting discussions today. And thank you again for your time.
Thank you.
Thank
You're
you.
welcome.
Thank you.
You're welcome.
Thanks,
Bye.
everyone.
Bye,
Bye.
guys. Thank you.
To all the primary care professionals listening, we'd love to hear your thoughts on how you manage medication shortages within your practices and PCNs. And thank you again for joining us. We'll see you next time on the Ashtons Primary Care Podcast. Thanks, guys.